Okay, we are done with psychiatric assessment and diagnosis. And in this video, we will talk about pharmacological therapy and electroconvulsive therapy. It will be, inshallah, some summary about pharmacological agents and biological agents in psychiatry in general. Pharmacological therapy and electroconvulsive therapy. So, psychotropic or mind altering, that's the meaning of psychotropic. Psychotropic medications can be divided into the following groups. We have antidepressants, mood stabilizers, antipsychotics, anxiolytics and hypnotics, and others. Despite its simplicity, this method of grouping drugs by the disorder they were first used to treat is flawed, because many drugs from one class are now used to treat disorders in another class. For example, antidepressants are first-line therapies for many anxiety disorders, and some antipsychotics also have mood stabilizing and antidepressant effects. And that's why you can find a lot of books nowadays describing psychotropic medications as their molecular function rather than clinical function. So, for example, Kaplan and Saddox would arrange the medications not according to this classification: antidepressants, mood stabilizers, and psychotic. No. Kaplan, for example, would describe drugs as SSRIs, SNRIs, D2 blockers, D2 partial agonist, serotonergic, according to the molecular function or the structure. For example, tricyclic, for example, MAO inhibitors, something like that. But roughly, we are still using these names, I would say: antidepressants, mood stabilizers, antipsychotics, anxiolytics, hypnotics, and so on. So let's start with antidepressants. History. Antidepressants were first used in the late 1950s with the appearance of the tricyclic antidepressant imipramine. This was the first. And the monoamine oxidase inhibitor phenelzine. Research into tricyclic antidepressants throughout the 1960s and 1970s resulted in the development of many more tricyclic agents and related compounds. A major development in the late 1980s was the arrival of the first selective serotonin reuptake inhibitor, which is fluoxetine. So starting from tricyclics, MAO inhibitors, then SSRIs, and we have a lot in between, of course. There has since been considerable expansion of the SSRI class, as well as the development of antidepressants such as mirtazapine and agomelatine that have other mechanisms of action. Let's talk about classification and mechanism of action. So we've talked about history. I think we need to replace that yellow. Okay. Classification and mechanism of action. At present, antidepressants are classified according to their pharmacological actions, as there is not yet an adequate explanation as to what exactly makes antidepressants work. Although there are many different classes of antidepressants, their common action is to elevate the levels of one or more monoamine neurotransmitters in the synaptic cleft. And actually, I would put a link for more molecular explanation in the description below. Okay. So we are talking about monoamine neurotransmitters: serotonin, norepinephrine, and adrenaline. norepinephrine and dopamine. So roughly, this is the mechanism of action. So this is the common action, is to elevate the levels of one or more monoamine neurotransmitters in the synaptic cleft. Some predominantly influence serotonin, some noradrenaline, and some dopamine, with many influencing the transporters or receptors for multiple neurotransmitters. It is likely that the combination of effects on multiple neurotransmitter pathways acts synergistically in causing the antidepressant effect. For example, agomelatine is both melatonin receptor agonist and 5-HT2C, which is serotonin 2C receptor antagonist. But neither of these actions alone have an antidepressant effect. We have this figure that illustrates the mechanism of action of antidepressant at synapses. So let's go to that one. And actually, I would recommend recommend the my explanation on Stahl's textbook about psychopharmacology. The link would be in the description below, so you can check that. It's about all of these things, but in easier way. So let's just review a lot of these things in general. So here we have serotonergic or noradrenergic nerve terminal. This figure just illustrates that. So we have, for example, we consider here that this neuron and these neurons are serotonergic or noradrenergic. So it's not like this in the real world. So the noradrenergic neuron is different from the serotonergic neuron. But here, just for simplifying things, they are represented here within the same figure. So we have this nerve terminal, we have this synaptic cleft, and this is the postsynaptic neuron. And as you know, the neurotransmitters are packed within vesicles within the presynaptic neuron. Then when there is action potential, the neurotransmitters will be released in the synaptic cleft. Then they would work on the receptors, the postsynaptic receptors, and sometimes the presynaptic receptors. And after they do their work, there will be some transporters that would reuptake neurotransmitters back to the neuron, then to be packed within the vesicles here. For example, here we have, serotonin, which is the purple cycle. Serotonin, or what's called 5-HT. It's the same thing, serotonin. Tryptophan is converted to serotonin, and then serotonin would be packed within vesicles. And then when there is an action potential, serotonin would be released. Serotonin would be after that would bind to its receptors, like serotonin receptors like 5-HT, according to 5-HT1A, 5-HT2A, 5-HT3, according to that. And after it finishes its role, it would be reuptaked by the serotonin reuptake pump, or what we call serotonin transporter, to get back to the neuron, and then to be packed within vesicles to be used when needed. The same thing for noradrenaline. Tyrosine is converted to dopa to dopamine, from dopamine to noradrenaline. Noradrenaline would be packed within vesicles, then released when needed. Then it would work on its receptors, and after that it would be reuptaked or transported via noradrenaline or norepinephrine reuptake pump, or what's called norepinephrine transporter. Okay. So this is a general thing. And another thing that you should know about, we have something called monoamine oxidase, A and B. Monoamine oxidase, it is an enzyme. It degrades monoamines. So it breaks down, you know, norepinephrine and serotonin and dopamine in general. So, how antidepressants work? Let's start with monoamine inhibitors. It's easy to be described here. Monoamine oxidase inhibitors, from the name you can know that it works by inhibition for this enzyme that would break down monoamines. That's how it works to increase, you know, monoamines. We have these examples like phenylzine, which is the first monoamine oxidase that was used to treat depression. We have trenyl cypromine, and we have these usually are irreversible inhibitors, but we have reversible inhibitors of monoamine oxidase A. We call them REMA, reversible inhibitors of monoamine, like moclobemide. Okay. How SSRI works? SSRI are specific serotonin reuptake inhibitors. From the name, it inhibits the, you know, these drugs inhibit the serotonin reuptake pump, and by that they, you know, increase the concentration of serotonin in the synaptic cleft because it stops the reuptake. Some examples are fluoxetine, sertraline, paroxetine, and citalopram. Other drugs like noradrenaline reuptake inhibitors or norepinephrine reuptake inhibitors like reboxetine, atomoxetine, works like SSRI but on norepinephrine reuptake pump, or what we call norepinephrine transporter. It inhibits that, and that's how it increases the, you know, concentration of norepinephrine within the synaptic clefts. All of these things are discussed in the link that I've told you about. So we are here just giving just a quick review about that. So it's okay if you don't know a lot of things here. What about, for example, noradrenergic and specific serotonergic antidepressants like mirtazapine? It works on a lot of neurotransmitters, but the special here is the work on alpha-2 noradrenergic receptors. So it works here to inhibit, you know, it will inhibit the inhibition of norepinephrine and serotonin. What about tricyclic antidepressants? Tricyclic antidepressants works on serotonin reuptake inhibitor pump and work on noradrenaline transporter also, in addition to other functions. We have a lot of examples here like amitriptyline, clomipramine, imipramine, lofipramine, and so on. Serotonin norepinephrine reuptake inhibitors, SNRIs, like venlafaxine and duloxetine, works the same thing here. We are talking about the therapeutic effect, but of course tricyclics has a lot more side effects because they work also on other binding sites like muscarinic and noradrenergic binding sites. We will go through these things later on. Bupropion is noradrenaline and dopamine reuptake inhibitor. It works on noradrenaline and dopamine. Dopamine is not mentioned here, but it has the same effect on, you know, increasing the monoamine the monoamine neurotransmitter concentration. So in general, you can see here that all of antidepressants work to end to that end to increase monoamine transmitters within synaptic clefts generally. Let's get back to the text. Okay. Okay, and we have a table that summarizes their classification and pharmacodynamics. Actually, we may look at that. So we have selective serotonin reuptake inhibitors. We've talked about that. They inhibit the serotonin reuptake pump or the serotonin transporter. Some examples like fluoxetine, sertraline, paroxetine, citalopram, and fluvoxamine. And the mechanism of action is to it does selective presynaptic blockage of serotonin reuptake pumps. What about serotonin and noradrenaline reuptake inhibitors like venlafaxine and duloxetine? The presynaptic blockage of both noradrenaline and, I like this name, norepinephrine, and serotonin reuptake pump, also dopamine in high doses, but with negligible effects on muscarinic, histaminergic, or alpha-adrenergic receptors. This will be in contrast with tricyclic antidepressants. That's why they mention this. What about noradrenergic and specific serotonergic antidepressants, NASA, like mirtazapine? They work on presynaptic alpha-2 receptor to block them, so that result in increased release of noradrenaline and serotonin from the presynaptic neurons. It also works on 5-HT2A and 5-HT2C and 3 receptor antagonist and histamine 1 receptor antagonist. What about 5-HT2C antagonist serotonin reuptake inhibitor? We call them SPARIs, like trazodone. They also antagonize at alpha-1 adrenergic receptors, histamine at type 1 receptors, and T-type calcium channel, which of its action is important in including its sedative and anxiolytic effects is unclear. This is trazodone. Tricyclic antidepressants like amitriptyline, lofipramine, clomipramine, imipramine, they work on presynaptic blockage of both noradrenaline and serotonin. We've talked about that, but also they have some blockage effect, a lot of blockage effect on muscarinic, histaminergic, and alpha-adrenergic receptors. That's why we have a lot of side effects in comparison with SNRIs, but we can use these side effects sometimes. We have less commonly used medications, at least nowadays, like MAO inhibitors like phenlazine and tranylcypromine and isocarboxazide. Okay, they are selective and irreversible inhibitors of monoamine oxidase A and B. We have reversible inhibitors of monoamine oxidase A like moclobemide. We've talked about that. We have NDRI, norepinephrine dopamine reuptake inhibitors. We have this example, bupropion. We have dopamine agonists like pramipixole and ropinirole. We have selective noradrenaline reuptake inhibitors like robuxetine. We have melatonin agonist and serotonin antagonist like agomelatine. They work on both melatonin receptors and serotonin 5-HT2C receptors. We have serotonin modulators and stimulators like vortioxetine. It works on selective serotonin reuptake as inhibitors, and they work on different 5-HT receptors, 1A as agonists, 1B as partial agonists, 1D, 3 and 7 as antagonists. Okay, I know this is a lot, but we should continue. The latest research has focused on monoamine neurotransmitter activation of second messenger signal transduction mechanisms. This results in the production of transcription factors that lead to the activation of genes controlling the expression of downstream targets, such as brain-derived neurotrophic factor. Brain-derived neurotrophic factor, BDNF, is neuroprotective and might be a key target of antidepressant action. And again, we've talked about a lot of these things while reviewing the style neuropsychiatry or psychopharmacology. I would put the link below. You should see that, because this chapter for me is just a quick revision for what was described there. So, hints and tips. When recommending antidepressants on trial in a patient with treatment-resistant depression, it makes sense to try those with different pharmacodynamic properties to antidepressants that have been trialed before. Okay, what are the indications of these antidepressants, as they're called? You can find this. SSRIs are used in the treatment of depression. That's why they call them antidepressants. But they are also used in the treatment of anxiety disorders, obsessive compulsive disorder. What about mirtazapine? Mirtazapine is used in the treatment of depression, particularly where sedation or increased oral intake is desirable. Tricyclic antidepressants are used in the treatment of depression, anxiety disorders, obsessive compulsive disorder. We are talking about clomipramine especially because it has a lot of serotonergic effect, and other causes like chronic pain, nocturnal enuresis, and narcolepsy. MAO inhibitors are used in the treatment of depression, especially atypical depression, and which is characterized by hypersomnia, overeating, and anxiety. MAO inhibitors are also used in anxiety disorders and other disorders like Parkinson's disease, migraine, prophylaxis, tuberculosis. Okay. Let's talk about some side effects and contraindications. Let's start with SSRIs. SSRIs and SNRIs. So let's start. SSRIs have fewer anticholinergic effects than tricyclic antidepressants and are not sedating. The majority of patients find them alerting, so they are prescribed to be taken in the morning. Soon after initiation or when taken at high doses, some patients can feel altered to the point of agitation or even anxiety. This may be associated with an increased risk for suicide, particularly in adolescents. Due to their low cardiotoxicity, SSRIs are the antidepressant of choice in patients with cardiac disease and in those who are at risk for taking an overdose. However, they do have their own side effects that may be unacceptable to some patients. These are summarized in the box below. Let's talk about some common side effects of SSRIs. We have GI disturbance like nausea, vomiting, diarrhea, and pain. Anxiety and agitation. These symptoms, GI disturbance and anxiety and agitation, are early. GI and anxiety symptoms occur on initiation of treatment and resolve with time. But we have other side effects. One of them is loss of appetite and weight loss, sometimes weight gain, but usually weight loss. Insomnia, sweating, sexual dysfunction like anorgasmia, delayed ejaculation. So, selective serotonin and noradrenaline reuptake inhibitors, SNRI, such as venlafaxine, have similar side effects to SSRI, but they tend to be more severe. So SNRIs have the same side effects of SSRI, except that they are somehow more severe. But let's just cardiac disease and those who are risk for taking an overdose. These are some indications that make us prefer SSRIs and SNRIs. Let's just continue. Contraindications. Aha, this should be highlighted in red. Contraindications. Mania, poorly controlled epilepsy, and prolonged QTC interval for citalopram and escitalopram, because it's according to the effect on QTC. But these are the contraindications. Okay, what about mirtazapine? Mirtazapine is very commonly associated with increased appetite, weight gain, and sedation. Via histamine antagonism. These side effects can be used to advantage in many patients. It is also associated with headache, dry mouth, and less commonly dizziness, postural hypotension, tremor, and peripheral edema. It has negligible anticholinergic effect. Contraindications, mania. Okay, that's not all actually. This is just a quick review. We will talk about these drugs one by one later on. Tricyclic antidepressants. This table, the next table summarizes the action side effects of tricyclic antidepressants. So we have the common side effects because of their blockage or binding sites, like anticholinergic side effects because of muscarinic receptor blockage. We have dry mouth, constipation, urinary retention, blurred vision. Okay, alpha adrenergic receptor blockage that causes hypotension, postural hypotension, dizziness, and syncope. Histaminergic receptor blockage would cause weight gain and sedation. Cardiotoxicity effects like QT interval prolongation, ST segment elevation, heart block, arrhythmias. Most of these side effects are related to the multi-receptor blocking effects of these drugs. The sedative side effect can be useful if patients have insomnia. Tricyclic antidepressants with prominent sedative effects include amitriptyline and clomipramine. Those with less sedative effects include lofipramine and imipramine. Due to their cardiotoxic effects, tricyclic antidepressants are dangerous in overdose, although lofipramine, a newer tricyclic antidepressant, has fewer antimuscarinic effects and so is relatively safe compared with other tricyclic antidepressants. Contraindications: recent myocardial infarction, arrhythmias, acute porphyria, mania, and high risk for overdose. Okay. Trazodone. Trazodone is a relatively weak antidepressant, but a good sedative. It is relatively safe in overdose and has negligible anticholinergic side effects. It is often used as an adjunctive antidepressant in those receiving non-sedative primary antidepressants like SSRIs. So the contraindications here the use of the tricyclic antidepressants, trazodone. And to remind you what trazodone do, trazodone is one of the serotonergic agents. It works on serotonin 2A and 2C as antagonism, and it blocks the reuptake inhibition of serotonin in some degree. Here we have a red flag. Antidepressants should be used with caution in patients with epilepsy, as they can increase seizure frequency, either by directly lowering the seizure threshold or by interacting with the metabolism of antiepileptics. However, depression is common and often untreated in patients with epilepsy, so it's important not to avoid antidepressants if they are indicated. SSRIs or SNRIs are usually recommended as first-line treatment. Okay, so despite it was written here as contraindication epilepsy, but it's not. It's a relative contraindication according to the case. We'll talk about these drugs one by one later on, inshallah. Let's talk about MAO inhibitors and REMAs. Due to the risk of serious interactions with certain food and other drugs, the MAO inhibitors have become second-line antidepressants. Their inhibition of monoamine oxidase A results in the accumulation of amine neurotransmitters and impairs the metabolism of some amines found in certain drugs, like decongestants and foodstuff like tyramine. Because MAO inhibitors bind irreversibly to monoamine oxidase A and B, amines may accumulate to dangerously high levels, which may precipitate a life-threatening hypertensive crisis. An example of this occurs when The ingestion of dietary tyramine results in a massive release of noradrenaline from indigenous stores. This is termed the cheese reaction because some mature cheeses contain high levels of tyramine that would cause this. We have a box that lists the drugs and foodstuff that should be avoided in patients taking MAO inhibitors. These are things. These are drugs and food that may precipitate a hypertensive crisis in combination with MAO inhibitors, and we should and we must actually avoid them. We have tyramine-rich foods like cheese, especially mature varieties like Stilton, degraded proteins like pickled herring, smoked fish, chicken liver, hung game, and such. Yeast and protein extract like Povril, Oxo, Marmot. We have Chianti wine, beer, broad bean pods, soya bean extract, overripe or unfresh food. Okay. We have some medications or substances that may cause the same hypertensive crisis in patients who use MAO inhibitors, like, adrenaline, epinephrine or noradrenaline themselves, amphetamines, cocaine, ephedrine, pseudoephedrine, phenylpropanolamine. These are some cough mixtures and decongestants. L-Dopa, dopamine, local anesthetic containing adrenaline, anything that would increase adrenaline in general. Okay. Here we have a red flag. An early warning sign of a hypertensive crisis is the throbbing headache. Check blood pressure in someone taking a MAO inhibitor who feels unwell. Okay. The reversible inhibitor of monoamine oxidase A, REMA, moclobamine, reversibly inhibits monoamine oxidase A. Therefore, the drug will be displaced from the enzyme as amine levels start to increase. So, although there is a small risk for developing a hypertensive crisis if high levels of tyramine are ingested, dietary restrictions are much less onerous. Okay. Here we have another red flag. An important red flag, actually. When other antidepressants that have a strong serotonergic effect, like selective serotonin reuptake inhibitors, clomipramine, imipramine, when these agents are administered simultaneously with MAO inhibitors, the risk for developing the potentially lethal serotonin syndrome is increased. Therefore, antidepressant wash-out periods are required if starting or stopping a MAO inhibitor. Check guidance for specific switch you are considering. We've talked about that also. Check the link again. Okay. MAO inhibitors may have further side effects similar to those induced by tricyclic antidepressants, including postural hypotension and anticholinergic effects. What are the contraindications of MAO inhibitors? Pheochromocytoma, cerebrovascular disease, and mania. You can understand that. Okay. Hints and tips. The abrupt withdrawal of any antidepressant may result in a discontinuation syndrome with symptoms such as gastrointestinal disturbance, agitation, dizziness, headache, tremor, and insomnia. SSRI with short half-lives like paroxetine and sertraline and venlafaxine are particular culprits. Therefore, All antidepressants, with the exception of fluoxetine, which has a long half-life, and many active metabolites, should be gradually tapered down before being withdrawn completely. So, we have another tip, communication tip. Although certain antidepressants may cause a discontinuation syndrome, they do not cause a dependence syndrome or addiction, in that patients do not become tolerant to them or crave them. Okay, what about mood stabilizers? These include lithium and the anticonvulsants valproate, carbamazepine, and lamotrigine. Antipsychotics such as quetiapine and olanzapine are also increasingly used in treating episodes of mania and in prophylactic mood stabilization. We will talk about them in chapter 22. Here we have some history points. In 1949, John Cade discovered that lithium salts caused lethargy when injected into animals, and later reported lithium's antimanic properties in humans. Trials in the 1950s and 1960s led to the drug entering mainstream practice in 1970. Valproate was first recognized as an effective anticonvulsant in 1962, along with carbamazepine and lamotrigine. It was shown to be effective in treating patients with bipolar affective disorder. Mechanism of action. It's not known how any of the mood stabilizers work. Lithium appears to modulate the neurotransmitter-induced activation of second messenger systems. Valproate, carbamazepine, and lamotrigine all inhibit the activity voltage-gated sodium channels and also enhance GABAergic neurotransmission. This is in general. What are the indications for mood stabilizers? Lithium is used in treatment of acute mania, prophylactic of bipolar affective disorder, prevention of relapse, and treatment of resistant depression. Treatment-resistant depression. We use lithium as an augmentation. What about valproate? Valproate is used in treatment of epilepsy, acute mania, prophylaxis of bipolar affective disorder as second line, and that's it. Carbamazepine is used to treat epilepsy, prophylaxis of bipolar affective disorder as third line. Lamotrigine is used to the treatment of epilepsy and prophylaxis of depressive episodes in bipolar affective disorder as third line. Here we have some hints and tips. Valproate is available in formulations as sodium valproate, valproic acid, and semi-sodium valproate, Dibacot. So we have sodium valproate, valproic acid, and valproate and semi-sodium valproate, which comprises equimolar amounts of sodium valproate and valproic acid. Different formulations have different equivalent doses, so prescribed by brand. So it's not okay to switch between, sodium valproate, valproic acid, and, semi-sodium valproate, because, so just stick to the brand. Side effects and contraindications. Let's start with lithium. Lithium has narrow therapeutic window between non-therapeutic and toxic blood levels. Lower levels can be toxic in older patients. So, therapeutic level is from 0.4 to 0.8 millimole per liter when used adjunctively for depression, and 0.6 to 1 millimole per liter for treatment of acute mania and for bipolar disorder prophylaxis. So, the toxic levels, okay, these are the therapeutic levels. And we have the toxic level more than 1.5 millimole per liter. Sometimes they call the therapeutic level is from 0.6 to 1.2 as I know. Anyways, dangerously toxic level more than 2, it would be lethal. Lithium is only taken orally and is excreted almost entirely by the kidneys. Clearance of lithium is decreased with renal impairment in older adults and in dehydration, and sodium depletion, of course. Certain drugs, such as diuretics, especially thiazides, non-steroidal anti-inflammatory drugs, NSAIDs, and angiotensin-converting enzymes, AC inhibitors, can also increase lithium levels and should ideally be avoided or prescribed with caution and frequent checks of lithium levels during initiation. Furthermore, antipsychotics may synergistically increase lithium-induced neurotoxicity. This is important as lithium and antipsychotics are often co-administered in acute mania. Here we have this table that summarizes the side effects and signs of toxicity of lithium. We have side effects like thirst, polydipsia, polyuria, weight gain, edema, fine tremor, precipitates or worsens skin problems, concentration and memory problem, hypothyroidism, hyperparathyroidism, impaired renal function, cardiac T-wave flattening or inversion, leukocytosis, teratogenicity. What about signs of toxicity? When we talk about toxicity from 1.5 to 2 millimole per liter, we may have nausea, vomiting, apathy, coarse tremor, ataxia, and muscle weakness. More than 2 millimole per liter, we may start having nystagmus, dysarthria, impaired consciousness, hyperactive tendon reflexes, oliguria, hypotension, convulsions, or even coma. The treatment of lithium toxicity is supportive, ensuring adequate hydration, renal function, and electrolyte balance. Anticonvulsants may be necessary for convulsions, and hemodialysis may be indicated in cases of renal failure. So it's according to the case. Here we have a red flag. Lithium toxicity can arise rapidly in someone who becomes dehydrated for any reason, like vomiting, diarrhea, inadequate fluid intake. Always check a random lithium level in someone who takes lithium and is physically unwell. It follows that the following investigations are needed prior to initiating therapy. Before you initiate, Full blood count, urea and electrolytes, calcium, thyroid function, pregnancy tests, of course in women of childbearing age, and electrocardiogram if cardiac disease or risk factors. So usually we're talking about full blood count, urea and electrolytes, and calcium and thyroid. Blood levels are monitored weekly after starting treatment until a therapeutic level has been stable for 2 consecutive weeks. Okay, so blood levels are monitored weekly after starting treatments until therapeutic level has been stable for 2 consecutive weeks. Lithium blood levels should then be monitored every 3 months for the first year, then every 6 months unless the patient is at high risk for complications from lithium or has poor concordance. Renal function, calcium and thyroid function should be monitored every 6 months or more frequently if there is any evidence of impairment. Contraindications and cautions: untreated hypothyroidism, heart failure, cardiac arrhythmia. Hypothyroidism, heart failure, cardiac arrhythmias. So, what about valproate, carbamazepine, and lamotrigine? These are You know, we'll talk about them. Just okay. Here we have this table that summarizes the side effects of carbamazepine, valproate, and lamotrigine. Valproate, carbamazepine, and lamotrigine. For valproate, we have increased appetite and weight gain, sedation and dizziness, ankle swelling, hair loss, nausea and vomiting, tremor, hematological abnormalities like prolongation of bleeding time, thrombocytopenia, leukopenia, raised liver enzymes, liver damage, and this is very common. We have serious blood and liver disorders, but are rare. For carbamazepine, nausea and vomiting, skin rashes, blurred or double vision, diplopia, ataxia, drowsiness, fatigue, hyponatremia, and fluid retention, hematological abnormalities, leukopenia, thrombocytopenia, eosinophilia, raised liver enzymes, hepatic or cholestatic jaundice, rarely. And for carbamazepine, also serious blood and liver disorders do occur but are rare. For lamotrigine, nausea and vomiting, skin rashes, consider withdrawal, headache, aggression, irritability, sedation and dizziness, and tremor, of course. And for lamotrigine, Stevens-Johnson syndrome can occur but it is rare. Okay. It's important to check liver and hematological functions prior to and soon after starting valproate or carbamazepine due to the risk of serious blood and hepatic disorders. Here we have a red flag. Valproate should not be prescribed in women of childbearing age unless alternative treatments are ineffective or not tolerated because of its high teratogenic risk. If valproate is to be prescribed, ensure the patient is aware of the risk for developmental disorders, approximately a third of births, and congenital malformations, approximately 1 in 10 babies, is using adequate contraception and knows to consult promptly if she does become pregnant. Okay, so another red flag about carbamazepine. Carbamazepine is a potent cytochrome P450 enzyme inducer. Before prescribing new medication for someone taking carbamazepine, check a drug interactions reference. Red flag about lamotrigine. Lamotrigine can rarely be associated with Stevens-Johnson syndrome, particularly in the first 8 weeks of use. Patients should be advised to stop immediately if there is development of rash, and reintroduction of lamotrigine at later date should be considered only by a specialist. Okay, this is about, and again, this is just a brief, quick review. It's not. Okay. What about antipsychotics? History and classification. Antipsychotics or neuroleptics, originally known as major tranquilizers, appeared in the early 1950s with the introduction of the phenothiazine chlorpromazine. A number of antipsychotics with a similar pharmacodynamic action soon followed. The butyrophenone, haloperidol in the 1960s. Their ability to treat psychotic symptoms had a profound impact on psychiatry, of course. accelerating the movement of patients out of asylums and into the community. However, serious motor side effects, extrapyramidal side effects, soon became apparent with all these drugs. Clozapine was the first antipsychotic with fewer extrapyramidal side effects, and thus was termed atypical. It led to the introduction of several other atypical or second-generation antipsychotics, including risperidone, olanzapine, and quetiapine. The older antipsychotics, such as haloperidol and chlorpromazine, became known as conventional or first-generation or typical antipsychotics. However, this distinction is increasingly viewed as artificial. All antipsychotics can induce extrapyramidal side effects if given at high enough doses. Clozapine is the only true atypical antipsychotic, in that it has a distinct receptor binding profile and can be effective in 2/3 of the patients for whom other antipsychotics have failed. Here we have this table that lists common antipsychotics. We have first-generation antipsychotics like chlorpromazine, haloperidol, cilpride, flopentixol, and zoclopentixol. Second-generation antipsychotic like clozapine, olanzapine, quetiapine, risperidone, and aripiprazole. We've talked a lot about them in this review, as I said before. Okay. Mechanism of action and side effects. And again, I'm just going through this quickly. The primary mechanism of action of all antipsychotics, with the possible exception of clozapine, is antagonism of dopamine D2 receptors in the mesolimbic dopamine pathway. Clozapine is comparatively weak D2 antagonist, but has high affinity for serotonin type 2 receptors, 5-HT2A receptors, and D4 receptors, among many other receptor targets. Most second-generation antipsychotics also block 5-HT2 receptors. Unfortunately, blockage of dopamine D2 receptors occurs throughout the brain, resulting in diverse side effects. In addition, antipsychotics also cause side effects by blocking muscarinic, antihistaminergic, and alpha-adrenergic receptors, as do tricyclic antidepressants. Here we have this figure and this table that summarize both the useful and troublesome clinical effects of D2 receptor antagonism, as well as the side effects caused by blockage of other receptors. So, as we know, for dopaminergic pathways, we have, the mesolimbic pathway, the mesolimbic pathway, mesocortical pathway, nigrostriatal pathway, and tuberoinfundibular pathway. And the, I would say the therapeutic effect is from the blockage in this pathway, the mesolimbic pathway. But the blockage within the mesocortical pathway or the mesocentral pathway would increase, something like negative effects. Nigrostriatal pathway would cause, the motor extrapyramidal side effects and such. And the tuberoinfundibular pathway would cause hyperprolactinemia. Anyway. For clinical effects and side effects of conventional antipsychotics, we have, dopamine D2 receptor antagonism. In the mesolimbic pathway, it involved the function of this pathway. It involved in delusions, hallucinations through thought disorders, euphoria, and drug dependence. That's why when we target this pathway, it would cause treatment of psychotic symptoms. While mesocortical pathway that mediate cognitive and negative symptoms of schizophrenia, the clinical effect of dopamine D2 receptor antagonism would worsen the negative and cognitive symptoms of schizophrenia. Nigrostriatal pathway from the basal ganglia to the striatum It controls motor movement. So the clinical effect of D2 antagonism would cause extrapyramidal side effects: Parkinsonian syndromes, acute dystonia, akathisia, tardive dyskinesia, and neuroleptic malignant syndrome. Some symptoms of neuroleptic malignant syndrome. Tubuloinfundibular pathway. It controls prolactin secretion, dopamine inhibition, prolactin release. So it controls prolactin secretion. That's what means by that's what dopamine do there. It inhibits prolactin release. So the clinical effect of dopamine D2 receptor antagonism would be hyperprolactinemia, and the symptoms would be something like galactorrhea, amenorrhea, and infertility and sexual dysfunction. Other D2 receptors like chemoreceptor trigger zone that controls nausea and vomiting, so that's why D2 receptors would have some anti-emetic effect. Okay, anyways. Other side effects for other receptors are anticholinergic side effects, muscarinic receptor blockers that cause dry mouth, constipation, urinary retention, and blurred vision. And this is usually for low potency drugs like chlorpromazine, for example. Alpha adrenergic receptor blockage, the same thing, but it's for postural hypotension, dizziness, and syncope. Histaminergic receptor blockage like sedation and weight gain. Cardiac effects, prolonged of QT interval, arrhythmias, myocarditis, or even sudden death. Metabolic effects, this is especially for second generation antipsychotic that increased risk for metabolic syndrome. Dermatological effect like photosensitivity, skin rashes, especially chlorpromazine that would cause blue-gray discoloration in the sun. And other side effects like lowering of seizure threshold, hepatotoxicity, cholestatic jaundice, pancytopenia, agranulocytosis, according to the agent itself. Okay. Learn this table well. Okay. These effects have a big impact on patients' quality of life and concordance, and as such as frequently asked exam questions. See also the table 21.1 for the relative frequency of side effects for some commonly used antipsychotics. We will get there in the right moment. Anyways, the risk for metabolic syndrome, obesity, diabetes, hypertension, and dyslipidemia is particularly high with clozapine and other second-generation antipsychotics. Metabolic syndrome is associated with increased cardiovascular mortality. So it's important to monitor and manage the components of this syndrome. Clozapine is associated with some rare serious side effects such as agranulocytosis, myocarditis, and cardiomyopathy, which means it is reserved for treatment-resistant cases. Okay. Here we have some hints and tips. If you can remember the side effects of tricyclic antidepressants, you can remember many of the side effects of antipsychotics, as both are multi-receptor blockers. Both groups are anticholinergic, dry mouth, constipation, blurred vision, and urinary retention, antiadrenergic, postural hypotension, and antihistaminergic, sedation and weight gain. Another hints and tips. Extrapyramidal symptoms are motor symptoms arising from the dysfunction of the striatum, part of the basal ganglia. The striatum provides input to the motor cortex and hence the upper motor neurons, corticospinal and corticobulbar tracts, which travel from cortex to spinal cord or cranial nerves nuclei. As these tracts pass through the brainstem, they form a bulge, which is termed the medullary pyramids. The term extrapyramidal emphasizes that different symptoms arise from disruption to the striatum than from disruption to motor cortex. Hemiparesis following a stroke, however, in both cases the motor control signals descend via the pyramids. Okay. Another hints and tips. The particular extrapyramidal side effects of Parkinsonism and dystonia are due to a relative deficiency of dopamine and an excess of acetylcholine induced by dopamine antagonism in the nigrostriatal pathway. This is why anticholinergic drugs are effective treatments, but not for akathisia, which has a different mechanism. Okay. Here we have this table that summarizes the antipsychotic-induced extrapyramidal side effects and treatment. So let's get there. Here we have some extrapyramidal side effects like Parkinsonism, dystonia, akathisia, and tardive dyskinesia. Parkinsonism and dystonia, the treatment is the same, but they have different description, of course. Parkinsonism, the description of Parkinsonism: muscular rigidity, bradykinesia, lack of or slowing of movement, resting tremor generally occurs within a month of starting antipsychotic. Dystonia, it's involuntary sustained muscular contractions or spasms like neck, spasmodic torticollis, clenched jaw, trismus, protruding tongue, eyes rolling upward. This is oculogyric crisis. It's more common in young men, usually occurs within 72 hours of treatment. The treatment for that is anticholinergics, procyclidine IV or IM if unable to swallow, and oral otherwise. Consider reducing dose of antipsychotic or switching to antipsychotic with fewer extrapyramidal side effects, like atypical antipsychotics. What about akathisia? Akathisia is subjective feeling of inner restlessness and muscular discomfort. Occurs within days to weeks of starting an antipsychotic. The treatment is propranolol for short-term, benzodiazepines. Consider reducing dose of antipsychotic or switching to antipsychotic with fewer extrapyramidal side effects, like atypicals. What about tardive dyskinesia? Tardive dyskinesia is rhythmic, involuntary movements of head, limbs, and trunk, especially chewing, grimacing, and making protruding, darting movements with the tongue. Develops in up to 20% of patients who receive long-term treatment with conventional antipsychotics. The treatment, actually, there is no effective treatment. Withdraw antipsychotic if possible. Clozapine might be helpful, and you should consider benzodiazepines, but you should not give anticholinergics because they may worsen tardive dyskinesia. So what about neuroleptic malignant syndrome? It's something else. Neuroleptic malignant syndrome, to distinguish between neuroleptic malignant syndrome and serotonin syndrome, on the other hand, you should know that we have some defining features. We have some neuromuscular abnormalities, the onset, the medication history, typical blood results, general treatment for all patients, and specific treatment options to consider. For neuroleptic malignant syndrome and serotonin syndrome, both conditions characterized by triad of neuromuscular abnormalities, altered consciousness level, and autonomic dysfunction, hyperthermia, sweating, tachycardia, unstable blood pressure. So we have this: neuromuscular abnormalities, altered consciousness level, and autonomic dysfunction, hyperthermia, sweating. Okay. About neuromuscular abnormalities. In neuroleptic malignant syndrome, there would be reduced activity. So we may have severe rigidity, lead pipe rigidity, stiff pharyngeal and thoracic muscles, may lead to dysphagia and dyspnea, and we may have bradyreflexia. On the other hand, the neuromuscular abnormality in serotonin syndrome It would be increased activity, myoclonus or clonus, hyperreflexia, tremor, muscular rigidity, less severe than neuroleptic malignant syndrome. But yes, it is rigidity, but it's about, clonus, tremors, hyperreflexia, and these things. What about onset? Neuroleptic malignant syndrome would be insidious, while serotonin syndrome is acute. Medication history usually occurs within 4 to 11 days of initiation or dose increase of dopamine antagonist. We are talking about antipsychotics mostly, but also with metoclopramide. Serotonin syndrome usually occurs after 1 or 2 doses of new serotonergic medication. The most common cause is concurrent SSRI and MAO inhibitor. Typical blood result. In neuroleptic malignant syndrome, you can find, even in serotonin syndrome, you can find elevated creatinine kinase, white cell count, and hepatic transaminase. All of these would be increased, and also metabolic acidosis. What about general treatment for all patients? For all patients, either with neuroleptic malignant syndrome and serotonin, we have general treatment options or guidelines, I would say. So you should discontinue offending drug, cool the patient, monitor and manage hydration and hemodynamics. So you need intravenous fluids, and consider intensive care monitoring and or ventilation. Monitor for complications like pneumonia, renal failure, and you can use benzodiazepines for sedation if agitated. Okay. What about specific treatment options to consider, depending on severity of illness? For neuroleptic malignant syndrome, you can use bromocriptine to reverse dopamine blockage, dantrolene to reduce muscle spasms, and electroconvulsive therapy. For serotonin syndrome, you can use 5-HT2A antagonist, which is cyproheptidine. Okay. The mortality rate for neuroleptic malignant syndrome is 20%. If untreated serotonin syndrome, the mortality rate is low. So that's it. So in both neuroleptic malignant syndrome and serotonin syndrome, we have neuromuscular abnormalities, altered consciousness, and autonomic dysfunction. And in both you can find some elevated creatinine kinase, white cell count, and hepatic transaminase, and with metabolic acidosis. And you can treat both of them by, discontinue the drug, cool the patient, monitor and manage hydration, IV fluids, and so on. Supportive therapy. And that's important to know, because even if you don't know how to treat, what's the exact diagnosis, it's okay, just treat the problem. But specifically for neuroleptic malignant syndrome, you may find something like reduced activity in comparison with serotonin with increased activity. And for neuroleptic malignant syndrome, you can use bromocriptine, dantrolene, and electroconvulsive therapy, while in serotonin syndrome, you can use cyproheptidine. That's it. So let's talk about anxiolytics and hypnotics. This is the last thing here. No, yeah? No, not yet. Okay, but we're close. A hypnotic drug is one that induces sleep. So this is a hypnotic drug. An anxiolytic drug is one that reduces anxiety. This differentiation is not particularly useful, as anxiolytic drugs can induce sleep when given in higher doses, and hypnotics can have a calming effect when given in lower doses. For example, the benzodiazepines, which are anxiolytics in low doses and hypnotics in high doses. This is reflected in the term sedative. Okay, so hypnotic, which means induce sleeping, anxiolytic, reduce anxiety. So sedative would do the job. sedative, which refers to both these effects and is generally used to refer to a drug with hypnotic and or anxiolytic effects. All such drugs can result in tolerance, dependence, and withdrawal symptoms. Furthermore, their effects when used in combination with alcohol are addictive. With what? Again. Furthermore, their effects when used in combination or with alcohol are addictive. Okay. The most important drugs in this group are the benzodiazepines and Z drugs, zopiclone, zolpidem, and zaleplone, which have very similar actions and indications. Here we have some tips. In the past, the antipsychotics have been referred to as the major tranquilizers and the anxiolytics as the minor tranquilizers. This is misleading because these drugs are not pharmacologically related. The antipsychotic do far more than just tranquilize. And third, the effect and use of anxiolytics is in no way minor. So, let's talk about history. In the 1960s, the benzodiazepines replaced the often abused barbiturates as the drugs of choice for the treatment of anxiety and insomnia. However, this initial enthusiasm was tempered by the observations that they were associated with serious dependence and withdrawal syndromes, and had gained a market as drugs of abuse. Z drugs were introduced in the 1990s and were initially thought to be less likely to cause dependence. This is not true. Nowadays, benzodiazepines and Z drugs are recognized as highly effective and relatively safe drugs when prescribed judiciously for short periods and with good patient education. Classification. From a clinical perspective, it's useful to group benzodiazepines and Z drugs according to their duration of action and route of administration. Here we have a table that summarizes these qualities in some common drugs. So here we have the drug name, the dose equivalent to 5 mg diazepam, the duration of action and time to peak effect, the half-life, and routes of administration. So here we have some benzodiazepines: midazolam, temazepam, lorazepam, nitrazepam, chlordiazepoxide, and diazepam. Okay. So midazolam 2.5 mg is equivalent to 5 mg of diazepam. It has short duration of action and the time to peak effect is 5 to 10 minutes. The half-life is 2 hours and the route of administration is oral mucosal solution, subcutaneous, and IV. Temazepam 10 mg, short duration 2 to 3 hours, peak effect, and 11 hours half-life. It is taken orally. Lorazepam 0.5 is equivalent to 5 diazepam. Short duration, the team peak from 1 to 4 hours, and the half-life is 15 hours. It can be given orally, IM, and IV. Okay. Nitrazepam 2.5, it has medium duration of action. The time to peak effect is 1 to 2 hours and the half-life is 30 hours. It is given orally. We have a chlordiazepoxide 15 mg, long duration of action. It takes 1 to 4 hours to reach the peak and 100 hours as half-life. It is given orally. And we have diazepam, 5 milligrams. Duration of action is long, 5 to 10 hours to reach the peak, and 100 hour as half-life. It can be given orally, per rectum, IV, IM, only if no alternative. Okay. What about Z drugs? Z drugs like zaleplone, zolpidem, and zopiclone. Zaleplone, 5 milligrams, very short, within 1 hour. Half-life is 1 hour also, given orally. Zolpidem, 5 milligrams, short, the peak within 1 hour, but the half-life is 2. Zopiclone, 3.375, short duration, 2 hours to the peak, and half-life of 5. It is given orally. It's not just like that. We have some other formulation to change the peak effect and the half-life. We will not talk about these in details because you can check the link below. Okay, Mechanism of action. Benzodiazepines potentiate the action of GABA. It's GABA-A specifically, the main inhibitory neurotransmitter in the brain. They are GABA-A positive allosteric modulators, that's it. They bind to specific benzodiazepine modulatory site on the GABA-A receptor complex, which results in an increased affinity of the complex for GABA, and so an increased flow of chloride ion into the cell. This hyperpolarizes the postsynaptic membrane and reduces neuronal excitability. Z drugs are also GABA-A positive allosteric modulators, binding to a different but neighboring site to benzodiazepines. What are the indications for benzodiazepines? And again, we've talked about all of these things in much more, I would say, fun way in the review of style, so go there, the link is below. Indications for benzodiazepines like insomnia, especially short-acting benzodiazepines, short-term use. Anxiety disorders, also for short-term use. Alcohol withdrawal, especially chlordiazepoxide. I think, okay, acute mania or psychosis, we use it for sedation, and we use it for akathisia, as we said before. Other indications like epilepsy, prophylaxis, seizures, muscle spasms, and anesthetic premedication. And we have some indications for Z drugs, and actually they are used for insomnia and just for short-term use. Side effects of benzodiazepines and Z drugs. First thing, the risk for developing dependence, especially with prolonged use and shorter acting drugs. Patients should be warranted about the potential dangers of driving or operating machinery due to drowsiness, ataxia, and reduced motor coordination. Use with great caution in older adults, where drowsiness, confusion, and ataxia can be precipitate falls or delirium. Use with caution in patients with chronic respiratory disease, like chronic obstructive pulmonary disease, sleep apnea, as they may suppress respiration. And actually, as I know, these side effects are much more potent, I would say, in benzodiazepines. But I don't know why maybe some British books would consider these drugs as dangerous drugs. I'm not sure about that. Okay, here we have some red flags. Benzodiazepines or Z drugs, zopiclone, zolpidem, and zaleplone, are seldom fatal in overdose if taken alone, but can be when taken in combination with other sedatives. So, flumazenil is an antagonist at the benzodiazepine site and can reverse the effects of both benzodiazepines and Z drugs, which bind close by. Another red flag: alcohol, opiates, barbiturates, tricyclic antidepressants, antihistamines, and other sedatives may all enhance the effects of benzodiazepines and Z drugs. Therefore, moderate doses of benzodiazepines in combination with some of these substances can result in respiratory depression. Quickly, about other hypnotics and anxiolytic agents, pregabalin is one of them. Is used to treat generalized anxiety disorder. It's structurally related to GABA, but does not act directly on receptors or enzymes that recognize GABA. Rather, it reduces the release of a range of neurotransmitters throughout binding to an auxiliary subunit of voltage-gated calcium channel. We are talking about alpha-2 delta. Anyways, gabapentin mechanism is very similar. We have buspirone, it's 5-HT1A receptor agonist that is used to treat generalized anxiety disorder. It is unrelated to benzodiazepines and does not have hypnotic, anticonvulsant, or muscle relaxant properties and is not associated with dependence or abuse. Response to treatment may take up to 2 weeks, unlike the benzodiazepines, which have an immediate anxiolytic effects. This is buspirone. Sedating antihistamines like diphenylhydramine are available for insomnia without a prescription. Unfortunately, their long duration of action may lead to drowsiness the following day. So this is about hypnotics and anxiolytics. We call them sedatives. Anyways, other drugs used in psychiatry. For alcohol dependence, we use acamprosate and disulfiram. We actually use also naltrexone. For opioid dependence, we use methadone, buprenorphine, lofexidine, and naltrexone. For dementia, we use cholinesterase inhibitors like domperidone, rivastigmine, and galantamine with NAMDA antagonists. These are memantine. Attention deficit hyperactivity disorders, we use stimulants like methylphenidates, dexamphetamine, and non-stimulants like atomoxetine, works on dopamine transporters. Okay. What about electroconvulsive therapy? History. The possibility that seizures could improve psychiatric symptoms arose from the observation that convulsions appeared to lead to an improvement of psychotic symptoms in patients with comorbid epilepsy and schizophrenia. This led to seizure being induced pharmacologically with intramuscular camphor in the early 1930s. An electric stimulus was later discovered to be an effective way of inducing seizures. Modern-day anesthetic induction agents and muscle relaxants make electroconvulsive therapy a highly safe and non-distressing procedure. ECT is a highly effective and often life-saving treatment for patients with serious mental illnesses. It is the most effective treatment known for severe depression, with an effect size of 0.9. Here we have some indications for ECT. ECT is predominantly used for depression and can be particularly effective in older patients. Okay, so ECT is predominantly used for depression and can be particularly effective in older adults. Although antidepressants are usually tried first, ECT is considered for the following features of depression. 1. Life-threatening, poor fluid intake. Second, strong suicidal intent, or psychotic features or stupor, or when antidepressants are ineffective or not tolerated. ECT is an effective treatment for severe mania, although in rare cases it can precipitate manic episodes in patients with bipolar affective disorder. Bipolar affective disorder in DSM-5, it is bipolar 1 disorder, you know. This is ICD. ECT is also an effective treatment for certain types of schizophrenia, catatonic states, positive psychotic symptoms, and schizoaffective disorder. ECT is also used for puerperal psychosis. We call it peripartal psychosis. Okay. With prominent mood symptoms or severe postnatal depression where a rapid improvement is necessary to reunite the mother with her baby. Administration and mechanism. How ECT is administered. ECT is administered 2 to 3 times per week. Most patients need between 4 to 12 treatments. An anesthetist okay. You know, the doctor of anesthesia. Okay, the anesthetist. The anesthetist. Yeah. The anesthetist administers a short-acting induction agent and muscle relaxant that ensure about 5 minutes of general anesthesia. During this time, a psychiatrist applies 2 electrodes to the patient's scalp in a bilateral or unilateral placement and delivers an electric current of sufficient charge to cause a generalized seizure for at least 15 seconds in duration. It is still not clear how ECT works. It causes a release of neurotransmitters as well as hypothalamic and pituitary hormones. It also affects neurotransmitter receptors and second messenger systems, of course, and results in a transient increase in blood-brain barrier permeability. So, side effects. The mortality rate associated with ECT is the same as that for any minor surgical procedure under general anesthesia, around 1 in 100,000. Loss of memory is a common complaint, particularly for events surrounding the ECT. Some patients also report some impairment of autobiographical memory. Unfortunately, studies that examine the long-term effects of ECT are difficult to perform. Memory impairment can be reduced by unilateral electrode placement as opposed to bilateral. Minor complaints such as confusion, headache, nausea, and muscle pains are experienced by 80% of patients. Anesthetic complications like arrhythmias and aspiration can be reduced by good preoperative assessment. Prolonged seizures may occur, especially in patients who are on drugs that lower the seizure threshold like antidepressants and antipsychotics. In contrast, benzodiazepines increase the seizure threshold, making it more difficult to induce a seizure of adequate length. What about contraindications? Actually, there are no absolute contraindication to ECT, but we have relative contraindications include heart disease, recent myocardial infarction, heart failure, ischemic heart disease, raised intracranial pressure, risk of cerebral bleeding like hypertension and recent stroke, and poor anesthetic risk. Here we have a note of ethics. Media portrayals of ECT have included its use as a punishment given without patient consent. In modern practice, a patient with capacity will make his or her own decision about committing ECT or not. A patient who lacks capacity may be given ECT without his or her consent if it is felt to be in his or her best interests. However, this requires a second opinion from an independent psychiatrist. Okay, we are done. Now to the summary. Chapter summary. Psychotropic medications are classed by the indication for which they were first licensed, but many medications are of benefit in other disorders. Antidepressants influence the serotonin, noradrenaline, and dopamine systems. Many antidepressants are well tolerated. Lithium requires regular monitoring of blood levels because high levels are toxic. Antipsychotics antagonize dopamine D2 receptors. Antipsychotics often have unpleasant and debilitating side effects. Benzodiazepines and Z-drugs both increase the activity of GABA-A receptors. Medications with shorter half-lives are more likely to cause discontinuation syndromes or symptoms. Lastly, we would say electroconvulsive therapy is a highly effective and safe treatment for severe mental illness. That's it. هذا والله تعالى أعلم، وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين. السلام عليكم.